Welcome to This Explainer. Today, we're diving straight into the microscopic cascades and clinical emergencies of surgical hemostasis. We're going to sharpen your clinical edge and bridge that gap from cellular injury all the way to real-world operating room crises. Let's go. We're moving rapidly through 4 phases today: primary hemostasis, the coagulation cascade, inherited disorders, and surgical emergencies.
Section 1. Primary hemostasis mechanisms. This is the initial vascular and platelet response to injury.
All right, let's hit our first question regarding the vascular phase. Which of the following is true? Is it A, mediated exclusively by systemic hormones? B, involves immediate vasoconstriction via TXA2 and endothelin-1? C, basal cells promote coagulation? Or D, vasoconstriction persists for hours without platelets? Take a second and lock in your guess. And the correct answer is B. The very second you get a vascular injury, the initial response is a local spasm driven by thromboxane A2 and endothelin-1. And check out this high-yield exam pearl. Remember that healthy, intact endothelium isn't just sitting there passively. It actively secretes nitric oxide and prostacyclin to make sure unwanted clots don't form. Okay, moving on, let's test your knowledge on platelet adhesion receptors. Now, this is a massive classic exam trap. What mediates that very first initial adhesion to the subendothelial matrix? Is it A, GPIB/3A to fibrinogen? B, GPIB9V to von Willebrand factor? C, GPVI to fibronectin? Or D, the ADP receptor to thrombin?
The answer here is B. This perfectly illustrates the crucial difference board examiners really want you to know. Glycoprotein IBXV is strictly for your initial adhesion to the vessel wall via von Willebrand factor. On the flip side, glycoprotein 2B/3A binds fibrinogen to bridge platelets together for aggregation. Adhesion versus aggregation. Make sure you keep those two completely distinct in your mind.
Section 2. The coagulation cascade and regulation. Time to look at the complex protein interactions.
Forget the old, isolated intrinsic and extrinsic pathways for a minute. Modern board exams are all about the cell-based model of hemostasis. So what are its 3 overlapping phases? Is it A, aggregation, secretion, agglutination? B, initiation, amplification, propagation? C, activation, adhesion, fibrinolysis? Or D, vasoconstriction, plug formation, retraction?
The answer is B. The absolute crucial point here is that coagulation isn't just randomly floating around in the blood. It actually happens in 3 highly localized steps right on cell surfaces. First, initiation, where tissue factor makes a tiny bit of thrombin. Then amplification, where that thrombin primes the platelets. And finally, propagation, creating a massive thrombin burst directly on the surface of those activated platelets. Now, to prevent that massive thrombin burst from just spiraling out of control, our bodies need physiological brakes. Which anticoagulant acts by directly degrading activated cofactors VA and 8-VA? A, antithrombin 3, B, tissue factor pathway inhibitor, C, activated protein C with protein S, or D, alpha-2 macroglobulin?
And the correct answer is C. Thrombin actually binds to thrombomodulin on intact endothelium to activate protein C. Then, using protein S as a cofactor, this activated protein C shuts down thrombin generation by cleaving factors VA and 8A. Remember your exam pearl here. Antithrombin 3 goes after factors 2A and 10A, but activated protein C selectively targets VA and 8A.
All right, let's look at a pretty fascinating clinical scenario where the lab values look completely alarming, but the patient is actually perfectly fine. A 24-year-old woman has a significantly prolonged APTT, a normal PT, and absolutely zero history of bleeding. Deficiencies in which factor would explain this? A, factor 7, B, factor 8, C, factor 12, or D, factor 10?
Answer C is correct. So a prolonged APTT with a normal PT points straight to the intrinsic pathway. Deficiencies in 8, 9, or 11 cause hemophilia and actual clinical bleeding. But I want you to burn this exam pearl into your memory right now. Factor 12, also known as Hageman factor, severely prolongs your APT in the test tube, but it causes 0 actual bleeding in the patient in vivo. Literally none.
Moving right along to Section 3, Inherited Bleeding Disorders. What happens when there are genetic flaws in the hemostatic system?
This dense vignette is an absolute classic. We have a 12-year-old boy with recurrent epistaxis, normal platelets, normal PT, mildly prolonged APTT. His impaired ristocetin aggregation completely corrects when you add normal plasma. What's the diagnosis? A. Hemophilia A. B. Bernard-Soulier syndrome. C. Glanzmann thrombasthenia. Or D. von Willebrand disease.
It's D. von Willebrand disease. A defect in VWF impairs platelet adhesion, and since it acts as a carrier for factor VIII, you're going to see a mild APTT prolongation. But the real crucial differentiator here is the ristocetin test. It corrects with normal plasma, simply because you are adding back the missing VWF. Bernard-Soulier, that doesn't correct, because the actual platelet receptor itself is what's missing from the patient's cells.
Building on our earlier receptor discussion, let's talk about Glanzmann thrombasthenia. This is characterized by a deficiency of which specific component? Is it A, the glycoprotein IB-IXV complex, B, the glycoprotein IB/3A receptor, C, dense granules, or D, von Willebrand factor?
The answer is B. Glanzmann thrombasthenia is an autosomal recessive deficiency of the glycoprotein 2B/3A receptor. And this brings us right back to our earlier rule. Without glycoprotein 2B/3A, platelets just cannot bind fibrinogen to bridge together. So you'll see a perfectly normal platelet count on your labs, but severe bleeding because there is literally zero aggregation capability.
All right, Section 4, Surgical Bleeding Emergencies. Let's dip directly into the operating room and tackle some high-stakes clinical crises.
Heparin-induced thrombocytopenia, or HIT, is a totally terrifying paradox on the surgical floor. Which statement here is false? A. It's mediated by IgG against heparin PF4. B. Platelets drop more than 50% at 5 to 10 days. C. There's a paradoxically high thrombosis risk. Or D. You must stop heparin and substitute low molecular weight heparin.
The false statement is D. Substituting low molecular weight heparin is strictly contraindicated. Why? Because it highly cross-reacts with HIT antibodies and just worsens the prothrombotic state. You must stop all heparin products immediately and switch to a direct thrombin inhibitor, like argatroban, or you can use fondaparinux, but never, ever use LMWH in this scenario.
Okay, for our final clinical scenario, you get called to the bedside of a 42-year-old male, 12 hours post-total thyroidectomy. He has a large, tense neck hematoma causing acute airway compromise. What is your most immediate step? A. Emergent CT scan. B. IV protamine sulfate. C. Bedside opening of the incision. Or D. Transport to interventional radiology.
The correct answer is absolutely C. Look, in this life-or-death scenario, compressing the trachea and impairing venous return will lead to rapid asphyxia. You do not wait for a CT scan, and you definitely don't wait for interventional radiology. You open that incision right at the bedside to instantly evacuate the clot and save their airway. Seconds matter here.
To wrap up this explainer, I'll leave you with this. Mastering these microscopic cascades isn't just about passing a board exam. It is the absolute foundation of keeping your patient alive when seconds count on the operating table. Think about how understanding these cellular mechanisms is going to change the way you approach your very next surgical patient. Thanks for joining me today, and keep learning.